And I'll turn it over to Gina. Thank you, Gina. We might have to.
Oh, okay. Okay. Over this to me. Okay, all right. All right. They can hear you. They say everything was okay.
Yeah, and then we want to make sure that everybody in the room can hear too.
Is my voice loud enough? Okay, okay. All right, I'll talk in my you're in trouble grandma voice. Okay. Okay. All right, again, my name's Gina Littlewolf-Millegan. I'm a registered nurse. I'm the infection prevention nurse and the employee health nurse. I am also currently the Ppe acting supervisor for a short more time. And do I just push? Let's see. How do I advance it?
Okay, there we go.
Okay. Yep. All right. So I did not know that my journey to become an infection preventionist started when I was 6 years old. I was indoctrinated into infection prevention in the era of tuberculosis. My grandmother worked at the Northern Cheyenne boarding school as a cook. And later she was a custodian for the BIA. My grandfather also worked there as a maintenance mechanic and a dorm matron. So for her being a cook at the Busby school, they had to learn how to sanitize. Let's see, I can't see my screen there. Okay, but growing up, the smell of bleach, it was very comforting to me, and that's kind of an odd thing for some people, but it was just as comforting as cedar and sweetgrass, because I guess that was more of a, you knew that the home was clean, so she kept the she taught us how to clean also at a young age to prevent that. Okay. Here, okay. Oops, we'll go back just a little bit. I remember, I guess I didn't realize then that I kind of idolized the white uniform that she always wore when she was a cook. Everything had to be bleached. I remember her routine, you know, go to town to do the laundry because the water was bad. We didn't have a washer and dryer in the home. It would turn it kind of a rust color. So she'd go do the laundry on Saturday. On Sunday, she'd press her uniform, and once a month she'd soak her white canvas shoes in the bleach, and everything was the 1-to-10 ratio, which still holds true today. And just disinfecting, when we talk about it, it can be confusing, is just one step above sanitizing. So if you're going to be working in a kitchen, everything had to be sanitized. But her and her cousins and her sisters that all worked in the same field in the kitchen were my role models, because they showed work ethic. They showed what it took to take care of other people, and they did that for many years. So again, how do I advance? Okay. So my background, 30 plus years in nursing. I've done inpatient, med-surg, labor delivery, outpatient, long-term care. I worked at the Bozeman nursing home. I've done the majority of my nursing care in ER, about 17 years of that. I've been a clinical director of nursing. I've learned PACU, and my current role is an infection preventionist and employee health at the Northern Cheyenne Hospital, at the Crow Service Unit. So looking at my notes here, just briefly to go over some of the basics and just infection control, and this can go into any field, not just the hospital setting. Hand hygiene is first and foremost the most important thing to learn and to teach your patients, the people that you serve, the staff. If everyone had done good hand hygiene at the beginning of the pandemic, it might not have been so bad. We would like to think that we all practice good hand hygiene, but It's not so easy. People get hurried. People, I know firsthand as an ER nurse, you get hurried when you see 5 people backed up in the waiting room. There's, other people that need your attention, and it's really easy to just hurry along and do that. But hand hygiene is really, really important, and it's the basics of your hospital acquired infection programs. Once you get those started, PPE, the proper donning and doffing, and I think they're trying to do away with those terms because it's confusing for some people, but donning is putting it on and doffing is taking it off. So there are a sequence to use when you put them on, and a sequence especially, and even more importantly, is when taking them off, that the proper order to take off your PPE so you don't cross-contaminate. CDC and the First Line have programs that, you can use those tools to help teach people at your facility for that. But I can't stress the importance enough of proper doffing so you don't cross-contaminate anything. Now, I've never tried the pudding. People always say put chocolate pudding on your hands and then take your stuff off with that, because you can see where that chocolate pudding is going to touch in areas that you don't think, that if you don't turn your gloves inside out, if you don't turn your gown the right way, you could end up with chocolate pudding in places you wouldn't think, in the back here, if you don't, untie properly. So that's just a good visual for people to use in that. The standard precautions. So you treat everybody like they have something that you can catch. So use gloves, proper hand washing, proper PPE for that. Always use gloves no matter what the patient's there for. Put them on before taking a blood pressure. Make sure you take them off. Get a new pair before you start something. And then there's transmission-based. Those are more specific to whatever disease you think they may be infected with or are infected with. A lot of people that are admitted to hospitals have a sign on their door, and if you never noticed it before walking through the halls, you'll notice it now. Some of them have little signs on the doors or flags up that will tell you if they're contact precautions. So that's one type of transmission based. There's droplet precautions, and there's also airborne precautions. So those are the different transmission based, and they all require a different level of PPE. And if you're going to be around them, so that's an important thing to learn when you're in the healthcare environment. And the last one is cleaning of the environment. Again, my grandma always trusted in bleach, and it pretty much killed everything as long as it had that contact time that we're going to talk about later. But you have to read every label of every cleaner disinfectant that you're using in your facility and use the manufacturer's instructions on there, because you can have 4 sets of cleaning wipes in front of you and they all may have a different contact time. One may be 1 minute, one may be 10 minutes, and that surface has to stay wet. It also has to be EPA approved before you use that. A lot of the products that we went through with COVID, we'd have to take to the infection control committee, and they'd have to be approved from the safety officer as well as the infection control officer. So that was a really important part. A lot of the companies had claims on them that they killed this, killed that, but if they were ever tested, that might not be true. So that's very important to go from the EPA list. In there, we had people bringing in their own cleaners. During the pandemic, they did not want you to use spray, and that was one of the hardest things to take away from people, the aerosol cans or the little spray bottles, because if someone had a high viral dose of COVID and coughed on the table, and then you come through there and spray it with it, you could potentially aerosolize it. So that was one of the things that was really hard for our environmental service techs or housekeeping to break away from, was just getting rid of all the spray bottles. And I still catch them every now and then with it. So that's kind of a hard thing to get rid of. Let me see. So those are the basics of infection prevention and control, just that anybody can do. I clicked on there. Okay. Okay, so during the pandemic, of course, like I said, there was not a lot of guidelines. We trusted one another. We trusted the CDC, read it every day, sometimes several times a day. But my role as the infection preventionist for the hospital included being a part of incident command. We did have to take the courses and do the certification in there. You had to understand your role in there. The mass training for the PPE, like I said, everybody in our facility was trained on how to don and doff the PPE, and we still do that now. Just in case we had an influx of patients and somebody that normally does your medical records would have to come out and register patients. So they'd have to learn how to put on the PPE, especially if we're having drive-through testing or for the vaccinations. So everybody had to be trained for an all hands on deck type scenario for the epidemic. Excuse me, quantitative fit testing. That is what our facility uses. Fit testing is when they put on the N95 and each employee is actually tested for how well it fits. A lot of places just have a hood that you put on after the mask, and they use saccharin, and they have you say things, bend your head a certain way, and if you can taste that sweetness, that mask doesn't fit right. You should try something else. So that's a pretty general way to do things. If you have issues with allergies, if you had a cold, if you have issues with taste or smelling things, that could affect your test. So the Crow Hospital has had the quantitative fit testing machines where they actually hook you up to it and have you do exercises on it. And it will tell you 100% if that mask is right for you. And I would really recommend going that route as opposed to the other one. A lot of places didn't have, we couldn't even order the hood ones to help speed up our fit testing when the pandemic hit. It's a good backup system, but I would really recommend going to the fit testing machines. We did developed a competency program to where we trained people from the site, and they had to do so many fit testings for that. And you'd be surprised at how many nurses did come through and say, oh, this model is what I've always used. Well, when we hooked them up to the machine, it wasn't protecting them the way it should be. So that really changed their perception on it. And we did a lot of them because during the pandemic, as you guys know, we ran out of PPE, people ran out of masks. So when we run out of one style of N95, we'd have to fit test everybody for the next bulk that came in. So I bet we've done thousands of tests. And like I said, it was one-on-one at the beginning. I have an assistant now, and she's invaluable to me. But that's all during the pandemic that it was focused on, was more so on employee health and getting the vaccinations. Screening employees and patients. The incident command was very, very good at being proactive on, we need to do this. We need to have just one way into the facility, making sure that we got machines that, took the temperature and kept track of everyone that was coming through. We had the vaccine clinics for both employees and for our patients. The contact tracing was enormous. I mean, some people, I don't know how many thousands that they were tracked as a contact. They were tracked if they were positive. We had to implement new programs and technology for our public health nurses to track people with that. And that was very, very, very helpful. We went to texting. People would check in every day. It would send a text. They'd check back that they were okay. If we didn't hear from them, somebody would call them back, and they could opt out of it too if they didn't want to share their phone number with that. So, and that was awesome. And let's see. So this was just part of the incident command. You had to be adaptive, innovative. Like I said, there wasn't much guidance when the pandemic first started. We were asking other service units, other clinics for help. What are you doing? Again, following the CDC guidelines, and everybody was coming up with some really great ideas. We met at least once a day. Somebody went to the tribal incident command. Somebody was on board with the county. So like I said, we were doing things at the same time. If the county changed their return to work requirements or isolation requirements or contact requirements, the tribe would do the same and Indian Health Service would do the same. So we were all on the same page. And we had great working relationships with the tribe and for the county. And our public health nurses were so invaluable. I'm so thankful to them. Let's see. Can't see the cursor. Oops. Okay. Oh, this is just a little more about the quantitative and qualitative. The quantitative was the use of the fit testing, very accurate, took extra time to train staff. You have to have a dedicated smaller room for that. It has a particle generator that you turn on before the tests, and then when they put the mask on, it sucks in through the mask, and if there's any holes in there, it'll pick up those particles. It can't just be a humidifier. You have to use a salt tablet in there. It picks up the ions in there as opposed to your breath. If somebody had a lot of water on their breath, it could skew that test and say it wasn't a good fit when it actually was. And it could be a little more time consuming. Now, from when the time I first started doing the fit testing, it was like a 2.5 minute process to actually do the test if it worked the first time. Sometimes we ran everybody through all 6 or 7 masks that we had. And if none of them worked, they had to use a PAPR. So if, the men have to be clean shaven. Sometimes they have to shave every day or it will not work. Your N95 will not work. The qualitative, like I said, the one with the hood that you put over and do the exercises in, it's a lot quicker. It's mobile. You didn't have to have a computer. You didn't have to have a machine. They could be done anywhere, but they just weren't as accurate. So this was the machine that we used. I'm not endorsing anybody or any one company, but there are a lot of different fit testing machines out there. So you can tell so back to the test, it was 2.5 minutes. Now it's down to about 35 seconds, I think, for a test. They've really done a really good abbreviated test. So this is the hood that they use for the qualitative testing, and it is just as good if you don't have the technology, but they have to have their taste and smell sense. You can't do it while they have a stuffy nose or allergies. Back to the mass PPE training. If I had known how short we were going to be on PPE, we might have done cloth gowns. But at the beginning, it was like, the yellow gowns. Everybody used the yellow gowns and threw them away. And but it's all for the better because we moved to the blue waterproof gowns now for our isolation gowns. Everyone in healthcare before that was used to seeing the yellow gowns for TB isolation. So, and these weren't fun to work in. If, it's just like wearing a trash bag, basically. You sweat a lot in there. It gets real hot. We do all have to do the annual PPE return demonstrations, the training for all staff. There's just a competency return demonstration that we have to have on file. Part of was the mask surveillance, and we still are doing that since we're still technically in the pandemic. Our facility, you have to wear a mask when you come in, when you see the provider. And part of the infection control program is mask surveillance. So we have people watching, are they wearing it right? Do they have it below their nose? Do they have it under their chin? And people are becoming a lot more relaxed in that, but we still monitor it and we report it at the monthly infection control meetings or prevention meetings. And then that goes on up to our governing board. And we were training to do the extended use for the PPE. We're really lucky that we didn't have to. We did the extended use for the N95s, but we didn't have to reprocess them. We were lucky enough to be able to tap into the national stockpile for the expired N95s, and that kept us going until supply was available. But people did all kinds of things like doing the UV light, reprocessing them in the room. We were going to use it was kind of like a little oven for the hydrogen peroxide to clean those. We had one of them ordered, but they never came in. So you had to be really creative in trying to get PPE for the staff. And of course, everywhere else, our elders, all patients, died, but our elders were a tough loss for us. On the Crow and Northern Cheyenne Reservation, they died alone. When they came to Crow and we were a COVID only unit, when they got bad enough to need a ventilator, which we didn't have, they would get shipped up to one of the hospitals at Billings. And it just seemed like it was a one-way door. They'd come in until they got bad enough to get shipped out. The CDC, excuse me, had a strike team that they sent to help do mass training for our physicians and our nurses. And one of the machines that they brought on board was a vapotherm machine, and it just gave high oxygen levels. So anybody that just generally has a nasal cannula, that usually only delivers about 5 liters a minute. This machine that they used and trained us for did about 45 liters. So it gave them a lot more oxygen in just that little tubing instead of having a mask on. And it did. I was telling them earlier, I said I cried when we sent our first elder home from the hospital that didn't have to go to Billings. So it did work. I mean, it really did work. Helped keep him off the ventilator, because a lot of people believed, once you go on the ventilator, you're not coming off, which was true in most cases. So that was very helpful to us. But yes, we did lose a lot of, excuse me, traditional ways, stories, some ceremonies, and probably some languages too. But as a Northern Cheyenne, I was always taught that, we will see them when we pass on. There's no word for goodbye, only we'll see you later. And I do believe we'll see them again. Let's see. Off on my notes a little bit here. So I preach to everybody that the infection preventionist shouldn't be something that you give somebody else as an extra duty. Most places find one of their best nurses. She gets stuff done. She's on time. She shows up for work, and she, is good with the patients, and they give her that extra duty to be an infection preventionist or employee health. And it just doesn't work out that way with all the requirements now, that all the areas, I should say, that are an infection preventionist does just encompasses so much more. It's a full-time job. Our hospital is a critical access hospital. We have about 380 employees. We're a 24-bed facility, and I'm simply not enough to do all the surveillance that it entails, all the rounds. So we're looking at getting help. I do have a full-time, not a full-time assistant. I split her with the safety officer, so she helps both of us. But even that isn't enough to address everything that has to be addressed when you're looking for infection control issues to prevent them. But again, the pandemics come around. I remember in the 90s, they were saying we were due for the next pandemic, and it didn't hit. The bird flu happened, but it wasn't as bad as people thought. And then I think historically, did they say it was every 50 or 75 years that a pandemic will come along? This one was overdue, probably by about 20 years or so. So they're always adapting. The bacteria and the viruses are always adapting. So, historically, it's not a matter of if it'll happen again, but when it'll happen again. And once my grandma realized what I did in my job, she shared a story with me about an illness that they experienced when she was a little girl. I think she said she was maybe 8 years old or so. And I did the math. She was born in 29, so it wasn't the Spanish flu. That's what I thought it was initially, but she said she remembers they were told to stay away from one another. She said they all had the bandanas on, like she liked Western. She said they had those masks on like they were bandits, you know. Everyone was wearing them. She said she remembers, I think there was 6 or 7 wagons that were lined up at the cemetery to bury their loved ones. And she just said it was a time that they were told to be quiet, you know, just to stay away from one another. So she had been through that already. Let's see. All right, so again, teamwork is essential, and I had heard this or read this at a conference somewhere, and one of the most dangerous phases spoken by leadership of an organization is we have always done it this way. So now that I've had the training that I do and a certification that I have, when I, you know, bring up something new that's out of the ordinary, I've heard this quite often, and it's a roadblock to change. You know, it fosters an environment of we do the bare minimum. We do not have to change, and our patients deserve better than that. The people that we serve deserve better than that. So I try to take that out of the language I use. And infection control is changing all the time. So we have to change to keep up with everything. Again, the core infection prevention and control basics were just the tip of the iceberg. In the training that I've done. And this is, so everything I've talked to up until now was really imperative during the pandemic, during the acute time when, you know, everything was shut down, and then the clinic started to open, and we realized that we were all this time we knew we were due for another cycle of accreditation for our hospital. So all those other things were always in the back of my mind, and I'd address them every now and then. And I just want to say the picture up on the left is a picture of a Petri dish of a child's hand. That's all the organisms that grew off of them, just pressing it on there, and they incubated it. And you think of all the kids that run around in the clinics, touching this, touching that, you know, and adults too. Adults can be very poor at hand hygiene themselves, but all those organisms could be really deadly to somebody that's immunocompromised if your environmental services people aren't keeping up, if your staff aren't cleaning the rooms in between patients. So on top of all the acute stuff during the pandemic, when you're doing your job as an infection preventionist, there's always the yearly review of policies. You have to look at the current standards from, depending on what your facility does, a multitude of places. My weakness, I will openly say, is surgery. I don't know what all encompasses an OR, to run an OR, so I've been having to do a lot of research on that. I'm trying to access the AORN guidelines for that, and I think somebody said it's over 1,500 pages for that. So just for the OR, yeah, just for the OR. Yeah, yep. Some light reading, but I don't have any experience besides I said PACU, and that's the post anesthesia recovery unit. So I've had to learn that, but I don't know everything that goes into it, and I'm slowly learning that, and I'm becoming more confident in it. And we've, need to update our policies on that. New accreditation standards are always happening. One of the ones that just earlier this year, one of the things that's required is to look at people for hand hygiene, basic hand hygiene. You have to look at every facility determines who should and should not have fingernail polish on. Some people just determine it's the OR crew and that's it, or people that are working with the cancer patients. At our facility, it's everybody that is involved in direct patient care contact, including the dietary staff, the nursing assistants, physical therapy. Anybody that has any contact with them has to keep their nails short, has no nail extenders. You can have nail polish, which is surprising as long as it's not cracked, or older than, I can't remember if it was 4 or 6, 3 days. How do you know that? I mean, we just discourage it. So that was a new development, but we never really looked for false nails in our healthcare. So that was one big change that came this year. The other one was the requirement to have a water management plan, and that helped stop the Legionella. It really had us look at our water. Legionella isn't going to hurt you if you drink it, but if you breathe it in, that's when it will cause an infection. So you just think of all the places that sat unused, our whole OB ward, our surgery ward, all that water that sat in there for years. You really need to circulate that water so that bacteria doesn't grow in there. So we did develop and pass a water management plan. So we just need to institute it. I think it just got passed by our executive committee, but once a week, if those rooms aren't used, you need to turn the water on and keep that bacteria from growing. So yeah, they had to address that. Then the National Hospital Safety Network, you got to do reporting in that. One thing that we did have to teach just about everybody in their new employee orientation was the how to break the chain of infection, how to break it. A lot of stuff, if you use sterile instruments in your facility, you really need to know this classification system. And it's the non-critical, semi-critical, and critical instruments and surfaces in your facility, because they're all cleaned in a different manner. We need to do the infection tracers. We do use the Joint Commission program to help us with our environmental rounds. And you can develop a tracer specific to that area, whether it's pediatrics, outpatient, dental, and it just does a crosswalk on there, and you can send a tracer out to the supervisor and say that if it was housekeeping, say there was bugs in the lights or that sink was dirty, and then they will send it back once it gets addressed. So that way, you know, it was addressed and it was closed. It just helps keep that going for quality purposes. The cleaning, monitoring, and disinfectants, like I said before, they all have to be EPA approved for COVID. And then along with that, all your other routine tracking, like what we'll learn from you, that still went on. We still had to track other diseases through our public health program and report them as well as that. So the biggest emphasis now is on environmental services. A lot of places, including us, classify our housekeepers as janitorial, or what is the other name for them? Custodial. Yes, to actually give them the training that they need to be environmental service technicians. And that's just saying that they have a lot more infection control principles and standards and certifications, which we'll talk about towards the end here. The point of care COVID testing, the education competencies, employee orientation, like was mentioned earlier, you have to have a specific departmental orientation for accreditation purposes. And I helped do the one for the EVS services, where they went over a lot of the stuff that they need to know about their job and why it's important to clean it in that way and follow the instructions on their cleaner. Oh, and this part, this was surprising to me. Your infection preventionist should be involved in any construction. any not demolition, but renovations in there, because the bigger the project, the more you have to watch out for, because there is quite a bit of bacteria and mold. If they're digging up the dirt that they raise shouldn't be coming into your building on your intake side of things. This ICRA, this infection control risk assessment, should be done before every project, even as little as IT running cables through your tiles that can produce particles for people to inhale, can set off an asthma attack, make any respiratory illness worse. Replacing the tiles, that was the big fight, because we found out that they were spray painting over the stains, but if your tile is stained, that's actually mold growing there, and it shouldn't be there. So if you have any stained tiles in your facility, those need to be changed right away. I hate to say that. Your maintenance people busy. Okay.
Painted it.
Yes, yes.
We need to
Yes. So, and surprisingly, and again, I'm not endorsing anybody, but we noticed with my iPhone with the camera on there, I could look at the ceiling with it through that camera, and sometimes I couldn't see it with my eye, but the camera would pick it up. So we had to confiscate the paint cans and and walk through there, and now they know that facilities is so much better at changing them out right away. And we've had a lot of roof leaks. So every organization should have an annual risk assessment based on what type of facility that you are. There's different matrices available. If you just Google it online, if you're an ambulatory, it'll just be ambulatory. If you're a hospital, but it's specific to your area, because some areas like back east, they wouldn't worry about hantavirus as much, or Lyme disease is more of an eastern United States. But all of that, hurricanes, floods, tornadoes, are they more prone to that? So you'll bring natural disasters in there. How frequent will it happen? How much would the damage be, and how costly it is? And that matrix calculates it at the end, and we take our highest area in each area, and then we address that in our infection control plan. Then you build a rail off of it to address those things. Do you need more training? Do you need more staff? Do you need to work more with the surrounding counties or tribes on how to address those? And then the usual bloodborne pathogens, competencies, exposures, OSHA reporting, those are always there. Those are always something that we've had to do. Employee health is the other part of my job that entails immunizations, COVID immunizations, TB, OPM employee files, which are separate than your electronic health record. They should be kept locked in a different place than your routine health record for your patients. The rules to that, there's a specific way that you need to set up the file for it. Respiratory protection program, you have to know the OSHA, the NIOSH, the CDC rules for that too, and make sure everyone's following all of them. Surgical procedures, there's we should have annual training and competencies for that, how to set up a sterile field versus surgical asepsis. You need to follow current AORN and AMI guidelines if you are sterilizing instruments in your facility. It isn't enough just to say we follow the CDC rules, because the CDC will refer you back to AMI and AORN guidelines. So it's all encompassed in that. You have to have a pandemic preparedness plan. We did ask the CDC to come and do an ICAR for us, a COVID ICAR, to tell us what we could improve on during the pandemic. And then our state epidemiology department came down and did it for free. I think most states do offer that for free if you ask them for an ICAR. They'll come in. There's a template that you can find online. The CDC does have it online. So just Google CDC ICAR and it'll give you a general guideline of what to go over. areas that you can look at on there. And then some specific to COVID also. Again, a requirement is a pandemic response plan and emergency preparedness plan. This isn't the sole responsibility of the infection preventionist. All maintenance should be involved, your physicians, nursing. So it's a group effort on this one, and it should be looked at annually also. And yes, we did make a lot of changes after COVID to ours. The infection preventionist should be a member of the Antimicrobial Stewardship Committee. They look at current practices on antibiotic dosing recommendations, what's working, what's not working. You should have a, they do a report every month. We have a report from the lab on how many MRSA wound swabs we have, how many nasal swabs we have, how many bloodstream infections we have, the organisms that caused it. And we do track that, and you have to report certain ones to the National Hospital Safety Network requirement, and we're under a critical access hospital, so there aren't as many for us to follow, but I am responsible for getting that data into that system by the 15th of every month. You do the exposure outbreak investigations, and the PHNs did a lot for us. And I already touched on the water management plan. So I took a class for the certified healthcare environmental services technician. I'm actually an instructor in that. I'm a trainer in that. That is for inpatient EVS staff. And you can get that through, it's the American Hospital Association, a subdivision, AHE is what it is. What is the Association for Healthcare and Environment? So I can teach the EVS people to get certified in there. And in the private sector, that's their gold standard, is to have your staff certified in this. They also have the certified surgical cleaning technicians, which is specific to the OR. And I just got done with that class. Again, our OR isn't open, but I hope to have them cross-trained into that. And then the last one is a certificate for non-acute care cleaning. That one would be more for your outpatient facilities that aren't a hospital. So those guidelines are there. I did look for our state of Montana, and the only ones that were certified in here were all in Helena, and our VA is located in Helena. So I think they have an instructor and that group that's there, mainly there. So that's something for them to strive for, and offer bonuses or higher pay once they become certified in that. The test has to be proctored by the instructor. And it's very important that they understand that you can take it more than once. You can take it until you pass it, because I know there's different degrees for literacy and learning depending on the age of the workers, but you can help them in so many ways to pass that test. Let's see. All right, so looking for the future, it really brought to light the need for us to have more infection preventionists for your facility. Again, it's not something that you should put on top of somebody's duties. I really do think that you need a dedicated infection preventionist for just all the stuff that I just went over. I've only been in this position for 3 years, and I had a lot of this learning to do, you know, not because of COVID, but because of accreditation also. So there's a lot of different areas that entail that, and they are, the training can be very specialized in that. So it's important to think that it should be one person dedicated to that position. All right, so I did mention that I was a certified infection or board certified CIC. So this was one of the programs that we were talking about earlier. So the CIC is certification in infection prevention and control. And that certification is done through the CBIC, the CBIC, and that's the Certification Board of Infection Control and Epidemiology. The CBIC is part of the APIC organization we were talking about, but they are geared towards the certification, not just for CIC. So every IP should be a member. I recommend them being a member of APIC nationally, and there's usually a state chapter. I think Montana actually has 2 chapters on that. So you get to see what's going on nationally when you're in that national group, but your local ones, they are so much more helpful to address concerns that may be going on locally, not what's going on in Florida or Alaska or, down in California. They give you more answers because, we all work better when we work together, and something that you might be experiencing, somebody already went through and has an answer for you, So it really comes in handy to be a member of that network. And again, the national APIC one were a lot of big facilities with, 6,000 beds, might have this issue, but all I'm talking about is, what do I do if our HVAC goes down? That's all I want to know. You have 20 of them to worry about and can get somebody there in a drop of a hat. We're in the middle of nowhere. How did you guys work through this? So they really were a good sounding board for that. So part of APIC, they do have this novice roadmap for infection preventionists, and that's a good place to start. It'll give you resources, email list to sign up for updates. They have the discussion boards. There's the APIC text that it costs a little extra, but if you get it with your membership, it'll be cheaper. And it covers a lot of stuff in there. They do the prep test for the CIC certification. They do a cleaning, disinfection, and sterilization class too. That would be really awesome. I think I would really highly recommend that. And again, if there's only one course that you can take, I would recommend the Ppe Intensive 1 and 2. And then again, they do have, they cover your role in construction and water and HVAC systems. So this is the one that I certified, have a certification in. It's more towards the RN, LPN, and they have different requirements. They reduced the requirement that you had to be in infection control from 2 years down to 1 for that one. And then, but there's more on their website on what you need to do to be prepared, the process, the fees and everything. Something new that they did come up with is this associate for infection prevention and control. And that is geared more towards anyone that is interested in infection prevention. It'll just increase your knowledge in that. And then once you have enough experience in that, you can sit for the actual CIC exam. And the one that's just newly come out, they're just now taking applications for, is the long-term care certification. I think they just started taking applications last week in that. And that was brought to light with all the deaths that we had in the nursing homes, that there really wasn't one program that everyone could go to get trained in what you needed to know in this. So APIC did come up with this program, and that would be very valuable if you guys are in long-term care. Our APIC chapter is using Project First Line. It's the CDC's National Training Collaborative for Healthcare Infection Control. We take a little video and someone teaches that to the rest of the class. It gets you comfortable with teaching other people. If you're not too good at that, it gives you all the visuals that you need. It can be done online, or your staff can take it when they have time to. But it, excuse me, it does deliver a comprehensive, transparent, and responsive training to people. And this ties in with Carmen's program, the National Indian Health Board, with what they were doing. I would recommend everybody take advantage of it because, again, we know that the money isn't there for everybody to do that. And if they have the scholarships for it, I was really happy when she told me that they offered the scholarships for people. You know, I didn't know that was her program was there. But for the classes, they can help you study for the classes. The prep classes for that, and help with the fees for the actual exam to take it. For me, it wasn't just a career. I mean, it's not just a job. It's become a career to me, and I can see where it expands more, you know, and it led to this field and this field, and that's what helped lead me here today to share what I have with you guys. You know, and during the pandemic, my grandmother did survive through COVID, and she, you know, she told us not to worry about her. We were so worried because she was alone. But she lived up to her word by saying she'd get through it. She did it with vaccinations, with social distancing. She had really good hand hygiene from her previous jobs, masking up, and one of her oldest weapons, bleach. So everybody had to have these fancy cleaners, and she said, as long as I have my bleach, I'll be okay. So, but yeah, those are some pictures of her. This one on the bottom was her actual first COVID vaccine that I took her to. So we had her gear on. But again, bringing us back to, you know, being prepared for the next pandemic, we need a warrior society. You can be a warrior for your tribe, for your people. It doesn't just mean, you know, in a combative way. You can be one to implement this program for your people. There's sports figures, you know, that can be warriors. Just being a role model for change can make you a warrior for your tribe. So I really, 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 really emphasize that we need to be ready and prepared for the next one, and be able to educate people on that, and know where your resources are. There's a lot of free resources out there to take advantage of. And it looks like that's it. I lost my notes here.
Thank you so much, Gina. Thank you for the presentation and sharing all the information, but most important, thank you for the work that you do for your tribe and for the tribal community, and just keeping our relatives safe. I really, really appreciate that. And we do have a few minutes for questions. For everybody on the Zoom, if you could share your questions in the chat, we'll start. Do we have any questions in the room? Yes.
How do you complete audits and international audits? Do you guys have secret shoppers, or are there supervisors that complete those audits? How do you go about doing that information?
Sure. I'll repeat the question first. The question is, how do they complete their hand hygiene audits, and who on their staff facilitates it?
Okay. So our hand hygiene program, we have forms, we have a secret shopper, and anybody can be part of that. We give them a number so they don't see it on the form. And then there's a second part is the supervisors. The supervisors in all the direct patient care areas are expected to hand in 6 observations a week. And it sounds like a lot, but if you go and just sit there and watch people, you can see those observations in probably less than an hour. And it's not trying to catch everybody doing something bad. It's also what they did right. They used the hand hygiene before they went in a room. That's one check. They used hand hygiene when they came out of the room. Somebody else took the dirty commode and put it in the room, and then took their gloves off and washed their hands. That's 3 things right there. So they're so easy once people are trained to what to look for. And we compile those every month, and that's reported to the Infection Prevention Committee. And then it goes on up to the Clinical Ancillary Committee, all the way up to the Governing Board. I report those. And our goal for our facility is to be at 90%. There have been many months where it was 100%. Of course, I'm not going to argue, but I know that it isn't 100%. And I've been trying to advocate for an automated one. There's some out there where you can use a badge, put them inside the door. If the staff walk in there without doing hand hygiene, they put the hand hygiene on, the gel on, and they have to put it over the badge. The badge senses it, and it'll stay green. And if they don't, they have so many seconds before it turns yellow, and then it'll turn red, and it won't turn green until you do your hand sanitizer on it. So, but you can get tens of thousands of hits every month on that, and that would be more accurate than somebody sitting there. Again, they consider direct observation the gold standard for it, but we don't have enough people just to sit there and watch everybody. So we take a little percentage of that. So we do have the forms that we hand out, and it's pretty much the same thing with the instructions, and try and involve everybody in that. So some months there hasn't been anything handed in. most of the time they neglected to turn it in, or they put everything on like the supervisor form. But then that goes back to your quality on what are you going to do to address that if it falls below that 90%. So hope that answered your question. Okay. Okay.
Thank you, Gina. I don't see any questions in the chat, but if you're on the Zoom, make sure to put questions in the chat if you have any. Do we have any more in the room here? Any other questions?
A lot of information,
It
so
is
I'm
a
sorry
lot.
it got dry, and I just it just went over everybody's. Yeah. So yeah, it is a very evolving job, and there's just so much responsibility in there.
I think I do have a question.
Mm.
So as infection from, what do you bring infection
So oh,
Okay, so the question in the room is, what, as an infection preventionist, what information do they give out to the community or to outside of healthcare?
so our guidelines that we use are always CDC. We get a lot of our handouts from them, and then the patient education. One of the things that for inpatient nursing, we're involved with giving them a pamphlet about if they came in with MRSA. This is the touchy subject that she was talking about how to avoid getting it, because we do have patients that come back. We treat them, they're colonized with it. They don't necessarily get sick with it, but every time they come back, their nasal swab is positive for it. So it's coming from the environment, not necessarily from their home, but these are things that you can do. And it all goes back to hand washing. Starting with hand washing, always make sure that you wash your hands. I'm one of the lucky ones that never have had COVID. I didn't have flu. I didn't have anything. And I like to think that it's from my experience of being a nurse and hand hygiene. And I would always tell my kids and my husband when hand hygiene became so important, don't touch your face. You know, try this at home. If you touch your face, you're gonna die. That's what I would tell them. And you'd be surprised at how many times they touch their face. You know, I'm sure I did it in this presentation, but you think about that, and before you eat, before you put anything in your mouth, always wash your hands. I don't care how old you are. that will keep you from getting sick. But yeah, no, that's how I was telling you. You practice that, you know, keep your hand away, see how long it takes. But yeah, I think we're so unaware of how many times we touch our face without, you know, we open the door, we move the chair, we touch this, we touch that, and then, you know, grab something and put it in our mouth, and, you know, you can get sick from that. So, but yeah, it goes back to the patient. And then for our staff, we have a quality newsletter that comes out every 3 months, and I put a lot of information on that. And again, I fall back to CDC. A lot of the stuff that we went over just recently is how to be safe during a cookout. I think that was one of their ones. And then the one before that was information on tick-borne diseases.
This is in the chat, no licking your fingers anymore.
Yes.
That sounds like a barbecue.
Or you lick your fingers to move the pages, you know. That was a hard one to break.
Yeah.
Do you have another question?
Yeah, I was going to ask, are you have resources in for awareness training at infection control risk assessment?
You know, I could teach someone how to do that, but I don't. There are online courses. I just found one, and I would have to send it to you. It's not that much. There's a couple of free programs online, but the construction one, I want to say it was less than $100. It was online. There was some modules that you take on how to do the construction one, and not every construction project needs to be. It'll tell you the different levels and which ones need to have daily surveillance on them. So the dust shields, the plastic up and everything. So
okay. Yeah, thank you. So yeah, we'd appreciate any resources for anybody here in the room or that you know of that may be helpful for anybody else doing the same job, share it with us, and we're happy to share it on our webpage and keep the things on our hub like I talked about earlier. We're happy to share that. I think if we don't have any other questions for Gina, we do have another presentation, but we can take about a 10-minute break and meet back here in 10 minutes and for Mandy's presentation on recognizing risks and then another short presentation on STIs, addressing STIs. So see you in 10 minutes.